Hello guys, today I will discuss about pulmonary hypertension. Pulmonary hypertension is called when pulmonary arterial blood pressure is 20 or greater than 20 millimeter of mercury, and it has got many causes. It can be idiopathic. In that case, it can be related to HIV, cocaine and appetite suppressants. Then pulmonary hypertension can be because of left heart problems, and then it can be because of lung problems when it is called cor pulmonale, and then chronic thromboembolic diseases. Whatever the cause of pulmonary hypertension is, it usually presents with dyspnea, fatigue, pedal edema, tachycardia, and signs are right ventricular heave, peristernal heave, P2 is loud, and there is raised JVP. Now, how do we treat pulmonary hypertension? Usually we do a vasodilator testing. We ask the patient to inhale NO2, nitrous oxide, and if the pulmonary arterial pressure it decreases in response to NO2, then the treatment of choice for pulmonary hypertension is calcium channel blocker, that is nifedipine. But if patient's pulmonary blood pressure does not decrease as a result of inhalation of NO2 or ileoprost perfusion, then the treatment is endothelial receptor antagonist, which include bosentan or imbesartan, which is selective endothelial receptor antagonist, and phosphodiesterase inhibitor like sildenafil, and prostaglandin analogs. But the definitive treatment is of underlying cause. For example, if it is due to left heart problem, then we have to treat that cause, or if it is due to lung problem, then we have to treat that cause. If it is because of not any known reason, then heart lung transplantation. After that, we'll discuss about interstitial lung diseases. In interstitial lung diseases, the ratio of FEV1 over FVC is greater than 0.7 because the decrease in FVC is more as compared to FEV1, in contrast to obstructive lung diseases. Now, the interstitial lung diseases, there can be many reasons of interstitial lung diseases. It can be because of extrinsic allergic alveolitis, sarcoidosis, then idiopathic pulmonary fibrosis, then there can be certain drugs, and asbestosis, silicosis, coal worker pneumoconiosis. So there are so many causes of interstitial lung diseases. But the important thing is that we need to know that there are certain interstitial lung diseases in which there is a restrictive pattern of obstruction, but the lungs, they are not the reason of that restrictive problem. It can be obesity, it can be kyphoscoliosis, ankylosing spondylitis, or any neuromuscular junction problem. All these things, they can cause dyspnea, and they can cause restriction over the lungs to expand, but the lung functions is usually normal. So FEV1 over FVC ratio is greater than 0.7, but if we calculate transfer factor, that is carbon monoxide is usually used to measure the diffusion capacity across the pulmonary membrane, and pulmonary membrane, it actually constitutes alveolar epithelium, then basement membrane, and then endothelium of pulmonary capillary. So diffusion capacity is the rate at which the gases they diffuse from within the alveoli to the blood vessels of the pulmonary vasculature. So TLCO in all these conditions is normal, which are not involving lungs. On the other hand, DCO, which is actually the transfer coefficient, which is a corrected lung volume for a given condition, it is increased because of hypoxia. Since these patients, they are hypoxic, obese patients, or because of kyphoscoliosis, these patients, they are hypoxic. So in order to compensate that hypoxia, the lungs which are left over, which are not being affected by that abnormality of skeleton, in those lungs, the transfer coefficient is increased, that is DCO is increased. Then there is another question which is very, very favorite, which is that in which condition TLCO is increased, that is diffusion capacity of carbon monoxide is increased. Of course, when there is polycythemia, increased hemoglobin, when there will be increased hemoglobin, there will be more extraction of oxygen from within the alveoli, increasing the diffusion capacity. Second is polycythemia, hemorrhage in the alveoli. When the blood will be present directly into the alveoli, obviously there will be no layers in between, so diffusion capacity will be increased. Then in left to right, shunting, obviously the amount of blood going to pulmonary vasculature will be both from the left heart as well as the right heart. When there will be more blood, there will be more hemoglobin. When there will be more hemoglobin, obviously diffusion capacity will be increased. Then it is also increased in exercise, hyperkinetic states, and asthma. So this is all about interstitial lung disease. One thing more, which is very favorite exam question, is that which conditions they affect upper lungs, or which conditions they cause fibrosis of the upper lung. So there is a mnemonic which is very important, which is CHARTS. C for cold worker pneumoconiosis, H for histoplasmosis and hypersensitivity pneumonitis, that is extrinsic allergic alveolitis. Then A for ankylosing spondylitis, R for radiation, T for tuberculosis, and S for silicosis. So these are the conditions which cause upper lung fibrosis. Thank you very much.